Good afternoon and good morning, everyone. My name is Paul Weber, and I am really pleased to finally be able to bring Dr. Michael Borg to teleclass education, or should I say back to teleclass education. He has presented several times in the past, but he is a devilishly hard man to get a hold of and to nail down. So I'm really delighted that we've got him today to speak about culture, context, and change, foundations for effective IPC interventions. Professor Borg is a microbiologist by training. He heads up the Department of Infection Control at Mater Dei Hospital in Malta. And he also chairs the country's National Antibiotic Committee. He's past chair of the International Federation of Infection Control and an advisor with the European Centre for Disease Control, the ECDC. He's been involved in a bunch of EU-funded projects on epidemiology of antimicrobial resistance and prevention and control of healthcare-associated infections, especially within the Mediterranean area. Now, Michael has authored or collaborated in more than 150 publications on these subjects. He's been included in the Stanford University list of the top 2%. I'll say that again, the top 2% most cited scientists worldwide. His latest research interests they focus on human behavior and change management. Surely very easy things, of course, and in the role in infection prevention and control. The topic today is culture, context, and change, foundations for effective IPC interventions. To present this, I give you Professor Michael Borg. Michael.
Thank you, Paul. Yeah, we finally managed to get here, right? After maybe a year and a half, but we're here now. So thank you for the invite. It's always a pleasure. And it's always a pleasure to talk about what you said already in the introduction, what is now probably my life's passion or whatever left of it, and that's basically behavior change. And this is an area where I've realized that, first of all, we have been grossly neglecting as a profession in infection prevention and control for the past number of decades. And more, we're realizing that this is probably the key if we really want to get any improvement in infection prevention and control. So, let me just, okay. Which is really strange, right? Because as IPC professionals, let's be a bit honest here, and I've been doing this for the best part of 30 years, it's not exactly that we do rocket science, right? I mean, we try to get our colleagues in our healthcare institutions to do things like better hand hygiene, adapt to standard and transmission precautions, do effective cleaning of the environment, management of invasive devices. I mean, it's pretty straightforward, especially when you consider that most of these colleagues, have far more onerous tasks in terms of medicine, nursing, etc. Yet, despite not really being in a rocket science profession, we can't exactly say that it's all plain sailing. I just quote some data from a very recent publication from the European Centre for Disease Prevention and Control, the ECDC, where they report in a very extensive report, and those of you in Europe, who are hearing this podcast, you're more than invited to just Google Point Prevalence Survey, ECDC, and you will get this full report. And one of the parameters that they looked at was actually the quantity of alcohol hand rub consumption in liters per 1,000 patient days by types of hospital. And in Europe, When we look at tertiary care hospitals, which of course are where most of the issues with IPC and HAIs and AMR tend to gravitate, the median consumption was in the region of 37 liters per 1,000 patient days, which at first glance seems quite impressive. But when you do a bit of extrapolations and admittedly include a number of assumptions, so you're assuming that one dose is 3 mils, which is usually the case. You're assuming that all the alcohol rub has been used by the staff, whereas we know that very often patients and visitors use it, so that would therefore impact. And you also assume that they're only using one dose, and very often, they hit the pump like there's no tomorrow. And maybe there is, as most papers suggest, another 25% of hand hygiene that is done through soap and water washing. And if you use all these assumptions together with that alcohol rub consumption, this equates to around 15 hand hygiene performances per patient per day. However, we know that there are much more hand hygiene opportunities. In fact, one of the best papers, the How to Study, suggests that over 24 hours, there are more than 70 hand hygiene opportunities in a general ward, and that's before even thinking about ICUs, in a tertiary care hospital, which is where we are talking about. So basically, what we're saying is that for the 70 opportunities that we expect to be happening every day, in Europe, probably somewhere in the region of 15 are being done. In other words, 15 years after the Clean Care is Safer Care, after 1.5 decades of continuously harping on the importance of hand hygiene to our colleagues, of policies, of posters, of goodness knows what initiatives we did, of Hand Hygiene Day on the 5th of May every year, still in Europe, and probably it's one of the better regions of the world, we have only managed to achieve a median hand hygiene compliance in the region of 25%. So basically, out of every 4 patient contacts gets a hand hygiene performance. And of course, we know that most of these hand hygiene performances will happen after patient contact because there's this self-protection perception. So again, we know that, of course, the most important is moment 1, moment 2. So clearly, we have an issue. So how do we explain this? How do we explain that we have, for 15 years, continuously went on education after education, campaign after campaign, World Hand Hygiene Day after World Hand Hygiene Day, yet still we struggle with such a basic intervention, a basic medical practice. And I believe that the solution, or at least the reason for this, is not medical. Doctors know that hand hygiene, they may not always accept it at face glance, but they know, inherently that hand hygiene is important for their patient safety. So why do we struggle? Well, I would put it to you, and it's because we're not looking at science in the sense that it's not medical science, but it's all about behavior. And when you introduce the concept of behavior into IPC and also into antibiotic stewardship, and we'll talk about it very briefly, but this presentation is primarily about IPC. When you introduce the element of human behavior, then things start to make a lot more sense. And we know that in terms of behavior, one of the most important drivers and facilitators and modifiers of behavior is indeed culture, which is the main topic of what I will be talking about in this presentation. So let's start with the basics. What is culture? Now, the most simple definition of culture is it's the way we do things around here. And the key word in that sentence is we. Okay? Why? Because culture relates to the values of a group. In other words, it is what a group holds as the standards of what is acceptable or not, what's important or not, what is even right or not. No? But the thing with culture is, and those values, is that those values differ. So a value that is deemed essential for one group may well be unacceptable to another. The same value is essential to one group, but deemed unacceptable to another. Now, the problem with values and cultural analysis is that they tend to be a bit abstract. When you're looking at these values, it's not easy to actually quantify and qualify what they are. And that's why cultural anthropologists very often work with cultural dimensions. So basically, cultural dimensions are constructs of identifiable behaviors and behavioral manifestations that provide a model to understand and compare cultural differences. And probably and arguably the most cited author in terms of at least national culture is this guy over here by the name of Geert Hofstede. He has passed away recently. He was a Dutch social scientist who probably is the most, or was the most active in terms of cultural analysis and cultural description. And indeed, Hofstede has described 6 dimensions that account for the differences in values and the differences in behaviors between countries. And these cultural dimensions are those that you're seeing there: power distance, individualism and collectivism, masculinity, uncertainty avoidance, long and short-term orientation, and indulgence versus restraint. Now, one of the most useful outcomes of Hofstede's research was not just the fact that he described these cultural dimensions, but he also managed to quantify them. And in fact, if you would, or if you're interested in this topic, that's the website for the Hofstede group, which is now called the Culture Factor. And you can, as you can see over there, you can enter the countries that you're interested in knowing about, and the site, and it's free of charge, will give you the individual scores for each of those 6 cultural dimensions for the countries that you have keyed in. And of course, when you have numbers, then you can start to do analysis, and you can start to do comparisons and associations and correlations. And in fact, when we look at antibiotic use in Europe, where we know that there is a very wide variation between countries, the key and the most important and consistent factor that has been correlated, and we'll come to it in a second, with various outcomes in relation to antibiotic use in Europe, the key factors are indeed culture and cultural dimensions, as you can see from the slide. And in fact, cultural dimensions and cultural determinants arguably best describe the significant variation of antibiotic use that we see between EU countries. And this relates to levels of consumption. So, for example, if you look at Scandinavian countries, they have very low levels of antibiotic use. And then as you go down, it increases and it hits the peak when you go to the Mediterranean and to the eastern part of the European Union. Cultural determinants have also been key to describe, at least in the past, because this thankfully has reduced across most of the EU, but they have described non-prescribed use or over-the-counter use of antibiotics. They have also shown a significant correlation with use in dubious presentations. In other words, in presentations such as colds, flu, and sore throat, which are typically viral, but for which antibiotics are still prescribed. And again, this is a phenomenon that you see in Southern and Eastern European countries in particular. Again, there have been publications, and one of them is mine, that show that, again, when you look at the use of broad-spectrum antibiotics and compare it, say, with the Scandinavians, where penicillin still remains, penicillin V still remains the treatment of choice in the community. And again, the only factor that has described this variability is culture. And finally, there are also publications looking at unnecessarily long surgical prophylaxis. In other words, giving antibiotics as prophylaxis for durations well in excess of 24 hours, which of course is what the literature suggests to be the maximum that you should give. However, it's not just in antibiotics that cultural dimensions or cultural factors appear to be relevant. Indeed, with a number of colleagues, we have identified that, for example, MRSA, which is probably one of the best indicators of IPC because of its clonal spread. Again, when you look at MRSA in Europe, it's very low in the north, increases as you go into the center, and then reaches its peak in the Mediterranean and in the Eastern European countries of the EU. And this variability is described, or at least attributed and correlated primarily, once again, with culture and cultural dimensions. Indeed, when you look at the cultural dimensions, 3 of those 6 dimensions that I mentioned show significant correlation with MRSA variation. And these are the ones I mentioned, namely power distance, masculinity, and uncertainty avoidance, which were also the 3 key dimensions that correlate with one or other of those antibiotic outcomes that I mentioned already. And it's not just with MRSA. So if you use the same model with these same 3 cultural dimensions at their relative levels of importance, and you correlate them with drug-bug combinations such as third-generation cephalosporin Klebsiella pneumoniae in Europe and carbapenem-resistant Pseudomonas aeruginosa, one probably more than the other, but quite clonally spreading organisms, again, you find a very significant correlation. So what are these 3 dimensions that I have been talking about now for the past few slides? Well, the key, and if you looked at the model in detail, you'd have found that the highest correlation for MRSA was with uncertainty avoidance. So what is uncertainty avoidance? Well, Hofstede describes uncertainty avoidance as the level by which a society, a nation, tolerates unpredictability and ambiguity in life. Of course, we all know that life is not predictable. You can wake up in the morning and think you're going to do something, and then by the evening you would have either done something completely different, or else, you've stumbled on a banana skin and all your plans have literally gone out of the window. And that is something which is part and parcel of life. Some societies handle this very well. They accept the ambiguity. They are not stressed by it. Whereas others find this extremely stressful and then do whatever they want, whatever they can in order to try and reduce the ambiguity. Now, very often people mix uncertainty avoidance with risk avoidance. These 2 are completely and utterly different. Okay, so I'll give you an example. So let's imagine we're in a hospital, a patient has been admitted, needed intravenous treatment, and now that treatment has been stopped, and the patient has an intravenous cannula still inserted. Risk avoidance would go on the lines of, well, if we've stopped IV treatment and the patient is drinking and eating normally, then he has no further need for a peripheral cannula. Keeping it in place would only risk thrombophlebitis and possibly sepsis. So our behavior should be we should remove it. Uncertainty avoidance, however, would go on the lines of, well, you never know, the patient may suddenly deteriorate, he may need an urgent IV treatment, and having a cannula inside you would be very useful. So let's keep it for now, just in case. And those three words are very often highly symptomatic of uncertainty avoidance. So what we see in uncertainty in countries that score high for uncertainty avoidance is that risk assessment, which of course is the cornerstone of IPC, is very often challenging and very often ignored. And it is ignored primarily if addressing the risk either causes personal uncertainty. I know that I need to perform hand hygiene, but I have so many other things to do, and I'm really flustered at the moment, so it has to take a back seat. Or else, as I'm saying already, conflict with other priorities. Cognitive dissonance, in other words, the rationalization that human beings do, tends to be more evident in countries that score high for uncertainty avoidance. And not surprisingly, these individuals in these countries prefer to take decisions based on anecdotal personal experience rather than guidelines which for them are highly impersonal and therefore written by someone else who may be completely different. Of course, crises are one of the most certainty-inducing situations. So you tend to find that things are done more by crisis than by planning, and very often issues are only addressed when they create a crisis. So, for example, many countries, and I've been to several country visits in these high uncertainty avoidance countries of Europe for ECDC, you speak to people and tell you, well, on a day-to-day basis, it is absolutely a nightmare to get our administrators to support us, to support the IPC program. But then when we have a crisis, when we have an outbreak, my goodness, the doors are open 6 times as much as they would be if there was proper planning. So how does this translate to IPC? Well, what we see is that in these countries, they will have rules and protocols. In fact, the key, the characteristic of high uncertainty avoidance countries is they are highly bureaucratic. They are highly dogmatic. So they're all for rules and protocols, but those rules and protocols end up staying on paper. And very often they're not followed, if either they're perceived as difficult to implement because of the uncertainty that this creates, or else if they clash with other commitments which are deemed more important and more certain. Okay? So managing a wound dressing, because that's my work, is certain, so I'll do it. The IPC that comes into it, it's taking too much time. Of course, change is one of the greatest uncertainty creating situations in life, so resistance to change tends to be more evident, and what the leaders do is very, very important, because if the leader does not walk the talk, then that in itself creates uncertainty, because, well, if he doesn't think it's important, why should I? And therefore, if senior staff or other professions whom are maybe higher in the hierarchical tree, and we'll mention that in a minute, are not performing IPC properly, then junior staff and other professionals will not prioritize them either. The other thing about high uncertainty avoidance cultures is that, of course, speaking out, going against the grain itself creates a level of uncertainty. So, of course, there is greater reluctance to speak up about breaches in IPC protocols, unsafe practices, or especially if this happens amongst senior members of the hospital. And because patient care, or at least doing what should be part of my job as a nurse, the typical nursing duties are prioritized because those are the certain components of the duties, then very often other requirements, especially if they're coming from third parties. So infection control areas, that's the role of the infection control department. They take care of it. I take care of what I need to do. I take care of my surgery. I'm a surgeon. I take care of my treatment if I'm a physician. I take care of the nursing if I'm a nurse. But infection control is something that is someone else's problem. Now, I'm pretty sure that there are those of you who are saying, wait a minute, this is something that I see myself, and I've looked at the list in the Hofstede group, and my country isn't particularly high in uncertainty avoidance. Yet I see these, from time to time in my hospital. And you would be correct, because cultural comparisons are not black or white. So when you're looking at cultural dimensions, even within the same society, there will be a normal distribution. You have some people who are very uncertainty avoiding. There are others who may have a very low uncertainty avoidance. And then, of course, you will have the median, which is the peak of the normal distribution. But when we study culture, we're not looking at individuals, we are looking at averages. So we're basically comparing the two medians of the two countries. So there aren't black or white cultures, they're all shades. Some shades are darker than others. And above all, there are no good or bad cultures, just different cultures. And a cultural characteristic may be challenging in a situation, but may be very useful in another. So, I always share our experiences in Malta with COVID-19, where, at least compared to other countries, especially those around us in the Mediterranean, our incidents and our impacts were pretty mild, over the 2 years that we faced COVID-19. And I attribute that, in fact, to our high uncertainty avoidance culture. So day-to-day IPC, not easy to implement. But when we had a crisis, when we had COVID-19, all the hospital literally pulled together, and the compliance to IPC protocols was exemplary. Of course, what happens once the crisis then abates, then the uncertainty also abates with it, and therefore the compliance takes a hit. The second dimension that I mentioned was power distance. And power distance is much easier to understand. It's all about hierarchy. So basically, it's George Orwell's quote that all animals are equal, but some animals are more equal than others. So what you find in countries which are high for power distance is that the power holders make all the important decisions. And they do them unilaterally. They do not regard consultation as required. In fact, in many cases, they see it as being a hindrance. Because they are the power holders, very often they lack in accountability because, of course, as we saw from Orwell's quote, the rules do not apply to them. But power distance is a relationship. Yes, the power holders hold the important decisions, but then what happens with the less powerful members of the society? They will basically defer decision-making, ownership, and responsibility to the power holders. In other words, you're calling the shots, you take the responsibility, and you take the ownership. But of course, we know that teamwork and collegiate collaboration is essential for IPC. And again, I've seen this firsthand in these country visits that I've done as an expert for the CDC, where these two key interventions very often struggle in countries with a high power distance. So how does this impact on IPC? Well, various, including, of course, the fact that in a high power distance society, if the leaders not prioritize or model good practices, then, of course, as we said already, for uncertainty avoidance, this just adds to that situation. Again, because of this power discrepancy, lower ranking staff will feel uncomfortable in voicing concerns, even more in criticizing the behavior of their leaders, because they know that if they do that, there will be repercussions. And this is something that very often we don't take into account, What is the consequence of this? Well, causes of HAIs, that very often are identified at grassroots level, will be missed or will be literally dampened down. So, how does this relate to the European landscape? Well, as we said, the European countries vary significantly, and they also vary significantly. In fact, it's the continent with most cultural variation, and they vary significantly in all the EU countries. So what you find is that the countries of the north, especially Scandinavia, British Isles, tend to be countries where power distance and uncertainty avoidance is low. Then as you go down into Europe, into the center of Europe, they increase. And then they reach their maximum to some extent in the Mediterranean, but especially in the eastern part of Europe. Now, if you put up on the screen, or I put up on the screen, another map, this time published by ECDC, looking at what I was mentioning already, the country prevalences of MRSA in the EU countries, you will see a very striking resemblance between the two maps. An extremely striking resemblance in terms of the coloration of those two maps. We also mentioned the third cultural dimension, and that is masculinity. Masculinity has nothing to do with the amount of muscles in the society, absolutely not. It's all about competitiveness and ambition in society. So masculine societies tend to be all about outcomes, objectives, the bottom line. They have heavy emphasis on targets and benchmarking. They value material success. They value assertiveness. Whereas feminine cultures tend to value more good relationships and cooperation. And of course, this is what you need if you want to have a successful IPC program. So what we see is that in high masculine cultures, because there's this priority for performance, it could lead to focus on individual goals, but more critically, and it can of course affect workplace dynamics as well as risk-taking, but the key impact on masculinity is the impact on outcomes. Now, we said that masculine societies value outcomes. They value the bottom line. So you would expect that highly masculine societies would therefore be the best in order to address IPC. The problem, however, is very often IPC is not the key priority. Very often hospitals will have other priorities: waiting times, bed occupancy, bed efficiency, number of operations performed. So if IPC is not the key indicator, the key performance indicator, then of course in masculine societies the focus will go on what is a priority. And we see this very well in the UK, for example. So the UK is a country with high masculinity scores, and in the 90s, their MRSA was very high. It was not a priority. The priority was hospital waiting lists, was hospital waiting times, actually. When, however, in the early noughties, MRSA bacteremia became a national target and hospitals were fined if they did not reduce their MRSA bacteremia rate, then suddenly it became a priority, and the success of the UK as a whole, including, of course, and especially England, in terms of MRSA bacteremia is something that is very clear in the literature and in past IPC history. Now, when we looked at the epidemiology of MRSA in Europe, when we published this a few years ago, another socio-cultural or social actually factor was identified, and this was the control of corruption. And what you find is that countries where the control of corruption is low tend to be those countries where MRSA is high. And this observation was not just ours. There are a number of papers in the literature that have also come to this conclusion. Some of their hypotheses, if I must be honest, I'm not exactly in agreement with. And in our paper, what we have suggested is that countries where the control of corruption is more lax tend to be those that have a general tolerance of deviant social norms, because at the end of the day, that is what corruption is. It is a deviant social norm. And it persists and proliferates because it is unchecked and unchallenged by the mainstream. So our hypothesis is that that same normalization of deviance will not stop at the front door of the hospital. It will apply throughout societies, throughout organizations, and of course in hospitals it will relate also to IPC and guidelines aimed to control MDROs. So just as corruption is tolerated, so is poor hand hygiene, and nobody takes the initiative to actually raise this and address it. So that is a brief overview about culture and how it impacts on IPC behavior. But the question, I guess, at the end of the day is, why bother? Because we know that national cultures have developed over millennia. So, for example, the spread of power distance in Europe, according to Hofstede, dates back to the Holy Roman Empire. That is how much this actually goes back. And cultures change very, very slowly. So if they change slowly, why bother studying them? Why bother learning about them? Well, I will quote a very nice book, which I really enjoyed reading, called Medicine and Culture. And the author, Lynn Payer, says, well, acknowledging the role of culture should not be an excuse for fatalism. I do believe you can change things, but I think you can change them more effectively if you know the culture you are up against. And that is why I have, over the past 10, 15 years, been so passionate to push this key behavioral concept in relation to IPC and antibiotic stewardship. Because I believe that if you understand your background culture, this is vital for any behavior change intervention, because that's what we're doing in IPC. And one of the benefits is that you can identify battles you are more likely to win in your background culture. And I will give you one example. And I'm always giving personal examples, because I believe that if you give a presentation, That's what you should do. You should identify what you're doing, whether you are actually putting into practice what you are talking about, whether you're walking the talk. So I will talk about one interesting component of IPC culture, if you want to store it that way, and that is patient empowerment. In other words, asking the patient or telling the patient, listen, ask your healthcare provider whether they have performed hand hygiene before they examine you, whether they treat you, whatever. Now, when you think about this, a patient in a hospital stopping his doctor and asking him or her, excuse me, have you performed hand hygiene before you come and see me? Now, what do you need for that? Well, you need assertiveness. The patient needs to be assertive. And we said assertiveness is all about masculinity. You need to have the temerity to address power holders. And for that, you need low power distance. And you also need low uncertainty avoidance, because, of course, this is a highly uncertain situation. I am going to stop someone who I depend on to give me the treatment that I require. Now, if we look at the publications that have been undertaken in relation to patient empowerment, these tend to come invariably from primarily Anglo-Saxon countries, from the UK, US, Australia, Canada. And if you look at the cultural dimensions of these countries, UK, USA, and Australia, they are almost identical. They are low in power distance, low in uncertainty avoidance, and low masculinity. So it's not surprising, therefore, that you come across a quote from this WHO publication from a survey respondent in the USA who was asked about actual patient empowerment and whether they would ask the doctor to perform hand hygiene. And her quote is very insightful. If the doctor said, please remind me, I would find it quite easy to say, well, you asked me to remind you, so I'm doing that. It would be similar to my saying why I was there and giving the doctor an update on the medication. Interestingly, they also asked a respondent from Slovenia. And her reply was, well, first, it's necessary to change, that word again, the cultural barriers. Patients have no right to tell physicians what to do. And indeed, if you look at the three cultural dimensions that I mentioned, you will see that they are diametrically opposite to the Anglo-Saxon countries in Slovenia, with high power distance, low masculinity, and high uncertainty avoidance. Now, if I look at where I come from, in Malta, which is my country, our cultural dimensions are very similar to those of Slovenia. We have high power distance, maybe not as high, but relatively higher than the Anglo-Saxons. We have lower masculinity, and we definitely have very high uncertainty avoidance. So with these three parameters, I have never pushed for patient empowerment. Because when we did in the beginning, and this was before the cultural enlightenment, which I always semi-jokingly say in these presentations, it was a complete failure. What happened was that patients were too stressed, obviously, to ask or to tell the doctors and the nurses to perform hand hygiene. And all that happened was that they realized that they were not getting safe care, because we had told them that if the doctor and the nurse doesn't perform hand hygiene, then this could lead to an infection, which could be serious. Now, just because we didn't do patient empowerment, it doesn't mean that we didn't push hand hygiene. Indeed, if you look at the point prevalence study, both the recent one and this is the one before, in our country, and of course, I live in a country that has at best 500,000 inhabitants, so my hospital, Mater Dei, is the key healthcare provider in the whole country. So when you look at our alcohol wrap consumption, it is as good, in fact, it's probably better than the vast majority of EU countries. So just because patient empowerment was not something we pushed doesn't mean that we gave up on hand hygiene. The only thing was that we adopted different interventions. We designed IPC interventions that were compatible with our national and organizational culture in our hospital. And in fact, we've published some of our results. I'm pretty chuffed and pretty proud, both with my team and with the hospital as a whole, that we managed to get a 90% reduction in healthcare-associated MRSA bacteremia over 10 years, something which very few, if any, Mediterranean hospitals can actually claim. And we did this through a number of interventions that were specifically tailored and adapted to our culture. And one of them was, in fact, what we were talking about before, hand hygiene. So we didn't go for patient empowerment, but we went for other interventions, an exhaustive amount of audits, because audits and the results of audits induce certainty. This is what your hand hygiene performance is, Mr. Charge Nurse of this world. Now, the problem with uncertainty avoidance, and I've mentioned it already, is ownership. Because very often you find that in high countries with high uncertainty avoidance, ownership tends to be challenging, especially ownership of a topic, of a subject, of a science, such as infection prevention, which, whether we like it or not, it's not easy for us to convince healthcare workers that it's their responsibility. So we had two options. We could either continue in this situation and try to be Pollyannic, and theoretical and say, well, it's their responsibility, they should take it. Or else we said, listen, this is our culture. This is what we have to accept is our challenge. So how can we address this? We centralized. So our interventions were fully centralized. So in terms of these audits, they weren't done by the staff of the ward, because obviously if we did, they would be all 100% compliant. Although, to be honest, if you look at some of the presentations in conferences, I think it's not just something that we would have found an issue with. So what we did was we fully centralized. We employed a person just to do hand hygiene audits in our own department, giving feedback in real time, constantly pushing reports, showing both where it wasn't good, but also where it was good. And where it was good, we celebrated. We organized meetings, we had a cake, we cut a cake for them, to actually encourage them. But when it wasn't, then there were consequences. And again, there was certainty. So we'd have a meeting, it would be done with the presence of the nursing director, the most senior hospital individual in nursing. The power distance comes in there as well. And in the meeting, the mantra was, what can we do to help you improve? But what you are asking us to do, we will do, but then we expect you to improve your performance. And it worked. It worked very significantly. The other thing that we introduced was root cause analysis. In other words, a program of systematic, formalized analysis of important adverse events, and we chose MRSA bacteremia, which identifies why they are happening. So basically, it's a forum for stakeholders, doctors, nurses, other individuals, stakeholders involved in the care of the patient, to look at the case, to come to an agreement what factors possibly led to the MRSA bacteremia, and then to develop effective corrective actions that were applicable to that ward or hopefully the whole hospital. In other words, introduce certainty. So what we did was, again, because of the power distance structure, because of the uncertainty avoidance background, everything was driven centrally by our IPC team. So we would review the case before, we would send the invites to the key stakeholders, we would look up possible standards of care, provide a summary of the case, and then, and this was critical, lead the meeting in a safe, non-punitive environment. We were taking ownership, true, but again, high uncertainty avoidance. The meeting, very importantly, and this of course can be challenging because we tend to be quite loud in our area of the Mediterranean, but it makes sure that everyone can provide the input that they want to give, keeping, of course, the focus on the issues, not the individuals. And then, once the meeting is over, we come up with action items that we send to the participants and critically copy to senior management, and then follow up to see if, in fact, the administration and the management, who very often are the key stakeholders in the improvement process, in the corrective actions, have actually done their bit. And if they didn't, then we would raise it again with them ourselves. So it was all a stream of certainty-inducing interventions. And then the third component, and you can see this in our publications, we've published all of this now, was admission screening. So we realized that we had a very high colonization rate, especially of patients coming into the hospital. So we started admission screening for all hospital patients, primarily, however, those in medical, surgical, orthopedic, and intensive care. We didn't go for a risk-based intervention, again, because to do that would have required the input of the peripheral areas of the hospital, in other words, of the wards of the A&E. And there wasn't ownership to do that. So we centralized this again, that focus, that word, centralization, because I believe it is critical when you have high uncertainty avoidance cultures. So basically, again, we employed staff specifically for this. Part of our department, they go through the patient list, the patient admission list every day, identify who was admitted, go to the wards, they swab them themselves, put them on the chromogenic plates and take them to the laboratory, who only need to see the next day if there is growth or not. This allowed us to achieve compliance rates, which very often you don't get in many other similar institutions, more than 98%. And if we then we look up the results the next day, identify those who are positive, and we phone the ward and give them instructions to start decolonization. So again, everything was completely centralized. And the reason for this is because, again, when you have dysfunctional systems, and this is why you get AMR, because hospital systems are dysfunctional. I have yet to visit a hospital which is high in MRSA, high in CRE, high in VRE, and you go around and you say how really efficient this place is. And this is the key, AMR, in my opinion, is a snapshot of the general system of the hospital or institution. Now, of course, universal admission screening wasn't exactly according to evidence. In fact, when we started out, the publications that were available all said no, universal screening has no benefit. You should only target high-risk patients and only screen those. However, the problem is that these studies originated primarily from countries with low colonization prevalence. And indeed, there are publications that now tell you, after we had started ours, that screening, clinical risk assessment screening, is cost-effective primarily in low prevalence settings. When you have very high prevalence, as we had at the beginning of our intervention in around 2010, then universal screening is the solution that you almost always have to go to. So I'll start to conclude, and I will conclude by quoting a few sentences from one of our more recent papers, where we actually, in fact, looked at why we went for universal admission screening. And we state in the paper, and I'm convinced with this, is that MRSA is driven by dysfunction. It's driven by cultural behaviors. And in such environments, you cannot simply have an intervention that assumes that things are being done properly. In such situations where you have high uncertainty avoidance, where you have low ownership, to put the onus of the intervention on the peripheral stakeholders is literally asking for failure. On the other hand, our approach, which was simple, it was centralized. Of course, it was very demanding. It was very intensive on our staff. But because it was centralized, we could manage it ourselves. And indeed, the conclusion of the second paper on the reduction in MRSA bacteremia, our conclusion was that transformational change was achieved by recognizing and understanding our cultural backgrounds and adapting interventions accordingly. So we live in a country which is high in power distance. When you have a high power distance country, you need to have top-down approaches. Now, it doesn't mean that you ignore everyone, that you just bulldoze your way through. No. We constantly communicated with the staff. We constantly gave them feedback. But the fact that it was highly centralized, that there was extensive day-to-day direct involvement of our team in our high uncertainty avoidance and power distance culture was extremely successful. And we're also successful because we were able to take procedures that were previously published, that were found to work, but we modified them if we thought they were culturally incompatible. So whereas evidence-based literature was used to inform the interventions, the setting, in other words, our hospital, was always considered, and as a result, the organizational context and environment of the intervention was customized. So to conclude, I strongly believe that infection prevention control is ultimately all about behavior change. And we've seen that cultural determinants, both national as well as organizational, we didn't have too much time to talk about those, but they are key drivers of human behavior. And therefore, since we are dealing with issues of human behavior, as IPC professionals, we need to understand and know human behavior. And we need to understand the cultural background where we are working in order to implement effective behavior change interventions that have the best chance of success. And this will involve identifying whether evidence-based, in inverted commas, IPC research, and it may be the best trial in the literature, but if it's done in a background that is completely different from your own, then its impact, its relevance needs to be assessed. Because ultimately, any intervention that you do needs to be culturally congruent. And to do so, let's all avoid copy and paste approaches. So leave copy and paste to your PC. And in the case of IPC, okay, so with PC, you do copy and paste. With IPC, you do cultural analysis and customized intervention. Because at the end of the day, culture eats strategy for breakfast. Thank you very much.
Michael, thank you very much. My brain is tingling. It's like just about every point you made. I tried to make some notes here. I've got all these little notepads full of scribblings that I will have no idea what they say later on. In a hospital, trying to change a top-down culture into something that's more collaborative. If the culture of the country isn't a collaborative culture, that's going to be very, very difficult, and that leader is going to burn himself out.
Let's just say that it's when you have certain cultural types or cultural dimensions and cultural backgrounds, some of them can be pretty challenging, and I know that from personal experience. But the thing is, this is it, Paul. So and I think this is where I think we have a big issue with IPC. Is that when you look at the literature in IPC, the vast majority, more than 80-90% of the literature comes from Anglo-Saxon countries. So it comes from the US, of course. A lot of it comes from the UK, and a significant proportion comes from Scandinavian countries, and especially with hand hygiene, but with other areas also from Australia. So, of course, as we saw already, these countries are actually in a bubble. They are the only countries in the world that have low uncertainty avoidance, low power distance, and high masculinity. In Scandinavia, not so much. In Scandinavia, there is low masculinity, but low uncertainty avoidance and low power distance, primarily these countries. So the concept of having collaborative, now collaboration is always important. As human beings, I think we all want to collaborate. It's part of our inherent human nature. We want to participate, but the level of initiative, the level of assertiveness, the level of decision making on my own is very much driven by culture. So, for example, I worked in the UK. In the UK, you'd have a policy. The head of the ward would have the policy. They would know it, and they would simply go to the policy and make decisions. In my hospital, that's a struggle. So we actually have, our department actually has one of our infection prevention and control nurses who is available on what we call reactive duty. So basically, the nurses phone for 101 things which are in the policy, but they want it from us. They don't want it from the policy. Now, I could say, well, no, because when I was in the UK, this is not what we did. You have to look at the policy. It won't work. So basically, we adapted it to us. So, for example, we're one of the few IPC teams that I know of that are actually on call 24/7. So after hours, one of the team is always on call because we get lots of questions and lots of queries, at least until 10 o'clock, and then they calm down. It's something that we have had to do. And if I must say, when you look at the point prevalence results, I think we're probably one of the best Mediterranean countries that in terms of outcomes, in terms of resistance. So, and it's all because we managed to create interventions and create systems that are culturally compatible.
Yeah, well, there's a challenge there, but certainly knowing your country's base culture, I think, is very valuable. My goodness, I wish I had more time to ask some questions, but we are in fact over time, so I'll end it there. There are 2 more teleclasses this month, both in the Americas series. Professor Michael Klompus will be speaking on the next pandemic. Are we prepared? I think the answer to that is probably no. And on the 20th, frugal innovation for low resource settings. That goes along with a teleclass lecture that we did last week from the World Health Organization and the state of infection control worldwide. I would like to acknowledge our patron sponsors, Diversity, Virox Technologies, and Gamma Healthcare for their support, without which teleclass education would be nearly impossible, because this program runs on a, well, let me say, we have never made money. And if we ever do, I think we'll be doing something wrong. So these guys help us break even. Thank you to everyone, and we'll talk to you again very soon. And again, Michael, thank you. That was a tremendous talk. I'm very, very interested. Very, very good. Thank you.
Thank you, Paul.